Good afternoon, everyone. We'll be discussing about the condition called as disorder of sex development or disorder of sexual differentiation, which is acronymed as DSD. Now, while defining or describing or discussing about DSDs, there are certain terms which are to be avoided as per the recent consensus guidelines like intersex, hermaphrodites, or third gender. Overall incidence of genital ambiguity is around 1 in 2000 to 4500 live births, while the prevalence of various different types of DSDs like XY females is 6.4 per lakh live birth females, androgen insensitivity syndrome 4.1 per lakh live birth babies, XY gonadal dysgenesis 1.5 per lakh live birth females. So, the disorder of sexual differentiation is a very complex and a complicated anomaly which is also controversial on various aspects. What are various types of DSDs? How do we define DSDs? So, for that, it could be due to the congenital development of ambiguous genitalia, like that of presence of clitoromegaly, micropenis, or there could be disjunct between the internal and the external sexual anatomies, like in that of congenital complete androgen insensitivity syndrome or 5 alpha reductase deficiency, where the chromosomal wise there is a male child, while that child has a presentation like that of a girl or has a genitalia resembling that of a girl. Incomplete development of sexual organs like vaginal agenesis, gonadal agenesis. Then there could be various sexual chromosomes anomaly or sex chromosome anomaly like that of Turner syndrome, Klinefelter syndrome, or various chromosomal mosaicism. Also, there could be disorder of gonadal development where there can be ovotesis noted. Now, there are various factors defined for the pathophysiology of DSDs. They are teratogen labeled, which are responsible for various genitourinary defects. Those can be maternal hyperthermia, like it can lead to micropenis, rubella virus, which can cause hypospadias or cryptorchidism. Progesterone agents, they can be one of the cause for ambiguous genitalia, oral contraceptives for hypospadias, and so on. These are the commonly studied teratogens. So, overall, if you'll see just from the previous slide, they can have associated chromosomal anomaly, there can be associated gonadal dysgenesis or agenesis, there can be receptor anomaly, there can be internal genitalia anomaly, or there can be external genitalia anomaly. So togetherly there can be various factors like genetic, chromosomal, environmental, hormonal, radiation, and so on. Just briefly discussing about the embryology of the genital organs. So what happens is that initially there is a primordial germ cell which migrates to the urogenital ridge, and there the gonadal development takes place, which differentiates into testes or into ovaries with the signals from various genes and with the actions of various hormones. Then there is development of internal genitalia, and then the external genitalia is formed, which is predominantly under the effect of DHT. This hormone potentiates or starts the development of phallus or the penis in the male. If it is absent or the receptors are not working properly, then it could lead to development of a female genitalia. So just in brief, there is an undifferentiated gonads which is from the primordial germ cell, which later differentiates into testis or ovary depending upon the SRY gene. And then if the testis is there, it will lead to production of testosterone and anti-Mullerian hormone. This testosterone will further get converted into DHT, which will lead to development of the external genitalia and the development or the maturation of Wolffian duct, which leads to epididymis, vas deferens, ejaculatory duct, external and internal male organs. And this anti-Mullerian hormone leads to regression of the Mullerian structures. While if this pathway is not followed, it's otherwise, then the ovaries are developed, and in absence of testosterone and anti-Mullerian hormone, the Mullerian structures develops. That is fallopian tubes, uterus, cervix, and upper one third of vagina. Now you can see over here there are primordial germ cell which later differentiates into testes or ovaries. There are Wolffian duct and the Mullerian duct, and this later on leads to development of the male internal organ and female internal organ respectively. Then I have already discussed about the male genitalia when we were discussing or when we were having the lecture on hypospadia. So I'll not go into much detail, but just in a brief, it's like there is a genital tubercle which will later leads to formation of the penis. There is a urethral groove between the urethral folds which will leads to formation of the urethra, and then there are labioscrotal swellings which will lead to formation of scrotum under the effect of DHT, or it will otherwise lead to formation of the labias. So this is the simultaneous development of external genitalia for a male fetus and a female fetus. So there are certain terminologies which should be taken into account when we are discussing about the case of DSD. Then there is a term called as sex, which is anatomically assigned. It can be genetic sex or chromosomal sex, which is decided on the basis of presence or absence of Y chromosome, that whether it's a boy or it's a girl. So it's a male or a female rather. Then there are gonadal sex, which is due to the presence or absence of testis determining factor. Then the phenotypic sex, or which is a secondary sex differentiation, which is due to the development of the secondary sexual characteristics. Then there is a phenotypic sex, also known as a secondary sex differentiation, which is what we see from outside. So the external genitalia is predominantly controlled by the hormone. So this secondary sexual or the sex differentiation is predominantly determined by the various hormones which are produced by the respective gonads. Then there is a gender. Gender is a social imprinting or personal recognition in the society, that whether the child is a girl or a boy. Then there is a psychosexual sex, which is gender identity, how one identifies oneself, what kind of brain imprinting that person has. A girl recognizing herself as a girl, a boy recognizing himself as a boy, and it can also be otherwise. So this is what it's a psychosexual sex is at the individual level. So as per the recent consensus, it was said that there are certain terminologies which should be taken into consideration and are being used these days. Like intersex has been replaced with the disorder of sex development. Male pseudohermaphrodite is being said as the 46XY-DSD. Female pseudohermaphrodite is 46XX-DSD. XX male is known as 46XX testicular DSD. True hermaphrodite is OVOTESTICULAR DSD, and anything that is associated with chromosomal mosaicism is sex chromosome DSD. Now it's a big list that how we decide or describe DSD. So I will not go into detail of each and everything. I'll just say that predominantly you have to see whether it's a sex chromosome DSD, which can be like Klinefelter, Turner's, or mixed gonadal dysgenesis. Then there are 46XY-DSD. So there it could be due to the disorders in the development of the testis or the gonadal testicular development, where it could be a gonadal dysgenesis, ovotesticular DSD, or testis regression. Then it could be due to the disorder in the synthesis or action of androgen, which can lead to so many other disorders related to synthesis and then the androgen action. So of this, androgen insensitivity syndrome is a more common entity. Then there are some other entities like it could be associated with various syndrome. There could be persistent Müllerian duct syndrome, vanishing testis syndrome, 46 XX-DSD. This is again, it could be due to the disorder in the ovarian development. Like there could be gonadal dysgenesis, ovotesticular DSD, or it could be a testicular DSD. Then it could be due to hormonal action, like there could be androgen excess, which could be at the fetal level. In this, it's a common cause is that of the congenital adrenal hyperplasia. Then there could be feto-placental, which is due to aromatase deficiency. Then it could be due to various maternal causes, like there could be virilizing tumors or the androgenic drugs intake by the mother. So when do you suspect that a child has DS? In neonatal age also they can present with an overt genital ambiguity, or there can be an emergency situation where a child is suddenly dehydrated into hypotension, there is a loss of salt in the body, and they can present to emergency requiring urgent resuscitation, especially the male baby. Other things are like virilized for other age groups, or you can say beyond infancy, early infancy children. They are they usually have virilized female external genitalia, where there can be enlarged clitoris, posterior labial fusion, inguinal or labial mass. Then the male could be undervirilized male external genitalia, where there could be bilateral the non-palpable testes, there could be micropenis, or there may be associated hypospadias or undescended testes. So beyond, they usually, if there is any ambiguity, they do present early to us, while beyond infancy also they come. There they can present with the previously unrecognized ambiguity. Male child, especially if they have hypospadias with associated undescended testes, yes, we look for any cause of we do suspect them to have DSD. That is a common presentation they present to us with. Then for female child, they may have inguinal hernia, or there could be an inguinal mass which needs to be evaluated. It could be due to the presence of testis or the missed case of DSD. They can also have incomplete or delayed puberty. There will be virilization with appearance of facial hair, beard, or the chest hair, body increasing, coarseness in the facial features, hoarseness of voice. So all these come under virilization. Then they can present with primary amenorrhea. Then for males, they are usually they may have gynecomastia, which is development of the breast tissues. They may have cyclic hematuria or suprapubic mass, or when they present with infertility. So these are the situations where one must suspect a case of DSD. Now they need to be evaluated properly, wherein we need to take a detailed history. Then a clinical examination is must. To support a clinical diagnosis or suspicion of DSD, one must go for karyotyping. Also, hormonal assessment at times is needed, depending upon various situations or the suspected diagnosis. We need to evaluate the level of various hormones. Then radiological assistance may be needed in terms of pelvic ultrasound, genitogram, MRIs, or MRU or the RGUs. Then we also can assess or evaluate their external genitalia utilizing pen endoscopy and laparotomy and laparoscopic approach. History taking, a family history of similar complaints should be taken into account. History of consanguinity, fertility issues, adoption, infertility is must. Any history of unexplained neonatal death in the family is of paramount, especially when a case of CAH is suspected. Then, family history of amenorrhea, delayed or early puberty is also helpful. Detailed history for maternal drug intakes should be taken, and other siblings should be evaluated, and it should be noted if they have any other, if they had any history of amenorrhea, delayed puberty, sexual behavior or preferences, then this should be taken into account. For clinical evaluation, general physical examination is done, wherein the built-in nutrition is taken into account, especially for the cases where we are suspecting salt wasting CAH. Hydration status and hypertension is must. It should be evaluated during the clinical examination. At times they may have other associated anomalies which should be taken into account. While examining the genitalia, it should be noted that how many number of orifices are there in the perineum, whether the genitalia is symmetrical or not, what is the shape, size and erectile tissue in the phallus. The phallus is usually the term that is to define the genitalia of the fetus. So what happens in the newborn if one is confused whether it is a penis, micropenis or a clitoris, then it's safer to use the term phallus. Meatus should be noted properly, that what's its shape, where it's placed, what is the size. Then also look for the labioscrotal fold, whether they are fused, whether what kind of pigmentation is there, whether there is associated transposition or not. Then while assessing for the gonads, one should look, if it's a male child, whether both the gonads are palpable in the scrotum. If not, whether it's a unilateral or bilateral undescended testis. One must look for inguinal hernia in both male and female if one is suspecting for the case of DSD. There are various methods or the various scoring are there for virilization or the masculinization. So for virilization, Prader staging is most commonly used, and while EMSSS is for masculizing scoring system. Chromosomal analysis or the karyotyping is must to support our diagnosis or suspicion for DSD, wherein a FISH or the G banding is done. Then followed by this, hormonal evaluation is being done, where one may need to go for even HCG stimulation test, and at time the level of other hormones like AMH, 17-OHP, testosterone, DHTs, they are being noted. With the help of radiology, we can also delineate various structures, and in cases of genitogram, you can see that this was a boy whose genitogram showed the entire Mullerian structure or the bilateral Mullerian structure with both the fallopian tubes and infantile uterus. Ultrasound pelvis, which can discuss or which can mention about the status of the presence or absence of Mullerian structures. Then pelvic MRI, and at times this RGU can help us to even look for presence of any vaginal pouch, or if there is Mullerian structure noted or there is Mullerian structure. So chromosomal analysis is being done utilizing FISH or the G banding method. It is the similar classification method, but in a more comprehensive way, as we have discussed. XX-DSD, XY-DSD, sex chromosomal DSD, it could be due to it. Sex chromosomal is straightforward. Mixed gonadal with mosaicism, Klinefelters, Turners, while XX and XY, it could be due to developmental disorders or due to androgen synthesis or action related disorders. If we are evaluating a case of XX-DSD, so what happens on ultrasound, a uterus could be appreciated. So then on we go for and look at the levels of 17 OHP, 17 hydroxyprogesterone, which is, if increased, is suggestive of the most common type of DSD, that is CAH, congenital adrenal hyperplasia. While if it is normal, then it could be due to ovotestis, which where a biopsy may be needed, and this could be a case of hermaphrodite, but we are not to call it, it's a ovotesticular DSD, or it could be due to maternal virilization or any external exposure of androgens. Congenital adrenal hyperplasia, which is the most common type of DSD, which with the incidence of 1 to 10,000 to 1 to 20,000 live births. It is due to the defect in the cholesterol synthesis pathway. There are a number of genes which can be affected, or there is disruption in the pathway at various levels, but three common, or the three most common pathways involved are these. This is 21 hydroxylase, then it is 11 beta hydroxylase, and 3 beta hydroxysteroid dehydrogenase. These are the three pathways which are most commonly affected or seen in cases of congenital adrenal hyperplasia. So if 21OH is deficient, so the entire pathway shifts to this side, and this leads to increase in the level of 17 OHP. So there will be more of the androgen, adrenal hyperplasia will be there, more and more androgens will be formed, so the female fetus will start having virilization, that is virilization of the female genitalia. However, the internal structures will remain unaffected. They may have clitoral hypertrophy, labial fusion, hyperpigmented pigmentation around the genitalia, and they may have a single urethral opening or a single opening in the vestibule, which could be due to urogenital sinus. And it's an autosomal recessive disease. That's why we emphasized that one should take the history of similar complaints in the family, history of consanguinity, especially for CH, which is the most common entity for DSD. Then for 11 beta hydroxylase deficiency, again this will lead to increase in the level of 17 OHP as well as 11 deoxycortisol. 11 deoxycortisol is the one which causes hypertension in these cases. So overall, there will again, like 21 hydroxylase deficiency, these patients will also have aldosterone and cortisol deficiency, but they will also have associated hypertension. Then 3 beta hydroxysteroid dehydrogenase deficiency will increase in the level of pregnenolone. So it can be the salt wasting, it could be simple virilizing, or it could be non-classic. Salt wasting is the most concerning part, where they may land up in the emergency with dehydration and the hyponatremia and hyperkalemia, and they need to be resuscitated immediately. While a simple virilizing is when there is defect onto the, or the anomaly onto the external genitalia only. So predominantly the clinical manifestation in cases of CAH depends upon, firstly, onto the aldosterone deficiency and cortisol deficiency, where there will be progressive weight loss, they may have dehydration, hypotension, hypoglycemia, hyponatremia, hyperkalemia. While for androgen excess, this is the another thing which will be there, due to which in the female child there will be ambiguous genitalia with the normal internal anatomy. Males usually have a normal genitalia in cases of CAH. Other things in this, that due to excessive steroids production, they may have premature closure of epiphysis, virilization will also be there. Another important thing is that if there is a history of CAH in the family and it's known, then in the subsequent pregnancies, antenatal diagnosis should be made. And this is possible utilizing a chronic villus sampling, which can be done in the first trimester and second trimester. This is usually utilized for the genetic assessment and to see what kind of which enzyme is deficient, to study that. And also more than it's important that one should know, look at the gender of the ingrowing fetus. If it is a female child, she will need the steroid supplementation throughout the pregnancy period. For treatment, it could be medical and the surgical. For medical, they need lifelong glucocorticoid replacement, which is done with the hydrocortisone with the daily doses of 10 to 20 mg per meter square, and they may need dose modification during various infections, stress, or surgery. While for some cases will also have will have mineralocorticoid deficiencies, for which they will need fludrocortisone. Antihypertensive is only supplemented in cases where BP is not controlled after glucocorticoid supplementation. Virilized female, they need a proper sex assignment, wherein they will need surgery for the female genitoplasty, wherein clitoral reduction methods would be utilized, or there can be the UGS resection will be there. Now XY-DSD. So in this again you will go with for the ultrasound pelvis, where you will look for the presence or absence of uterus. If uterus is not there, then you will go for HCG stimulation test and look at the level of testosterone and DHT. If it is normal or increased, then it could be due to androgen insensitivity syndrome. If it is if testosterone is normal but DHT is less, then it could be due to 5-alpha reductase deficiency. I'll just go few slides back and will show you that 5-alpha reductase is here testosterone to dehydroxytestosterone. So while there will be other cases where the testosterone and DHT will be decreased while LH and FSH will be increased, it could be in the cases of gonadal dysgenesis or Leydig cell hypoplasia. If their uterus is present on ultrasound pelvis, then it could be due to true hermaphrodite or ovotesticular DSD, or in cases of persistent Mullerian duct syndrome. Three common 46XY-DSD are complete androgen insensitivity syndrome, partial androgen insensitivity syndrome, 5-alpha reductase deficiency syndrome. So I'll just describe about these three. Wherein complete androgen insensitivity syndrome, there is complete absence of androgen action. So phenotypically, or the external genitalia will look like female child, and there may or may not be a palpable gonad, but testis will be there, which could be intra-abdominal or in the inguinal canal. Usually have increased luteinizing hormone, testosterone and estrogen, which is due to the feedback, which is again and again increasing the LH secretion in the brain. Later it's causing excess release of testosterone and estrogen. There is no uptake or the sensitivity of the receptor for the same. However, they have no Mullerian structures, so they are usually raised as female child, who may have inguinal hernia or may have palpable lump in the inguinal region, and at times they are brought to the clinics when there is a complaint of primary amenorrhea. The partial androgen insensitivity syndrome is when the androgen receptor disorder is there, but the level of testosterone is normal. So there is a variation in them, that they can have a phenotype of female with a clitoromegaly, or it can go up to a male phenotype with hypospadias or presenting with micropenis or UTT. 5-alpha reductase deficiency, they again can have a variation in the phenotypic presentation. Now, HCG stimulation test usually shows that the testosterone is normal while DHT is decreased in them. So, they usually have raised testosterone to DHT level. What is a catch point in these patients is that they are raised as females, but when they reach puberty, their secondary sexual character starts developing. Even there is increase in the penile length, so at puberty they become boy like. They are they get or converted more into a boy like. So usually it is said that in cases of 5-alpha reductase deficiency, the surgery should be delayed till puberty. Now, sex chromosome DSDs, it includes mixed gonadal DSD, Turner syndrome or Klinefelter syndrome. So, mixed gonadal DSD is what happens, that there is asymmetry in the external genitalia, where the half of the genitalia, or there is scrotal better or well defined scrotal folds on one side, while there is a poor scrotal differentiation onto the other side. There may be a genital ambiguity or hernia seen in this patient. As there has been noted that they have a variable karyotype which could be 45XO with 46XY, or 46XY is a pure case. So, and various mosaicism is also noted in cases of mixed gonadal DSD. There, one of the tissue is testicular, which can lead to the virilization in these patients, and the other side, it's a streak gonad with Mullerian structures. Other sex chromosome DSD is the Turner syndrome 45XO, which has got a very classical phenotypic features of web neck, chest, shield, various associated cardiac anomalies. Klinefelter syndrome, it has an extra or the additional X chromosome in them. These patients are also have hypogonadism. So the characteristic, all the phenotypic features are mentioned in these two figures. Another type of DSD is ovotesticular DSD. In this, again, the external genitalia can be asymmetrical, there can be genital ambiguity or inguinal hernia. As the name suggests, ovotesticular, they will have normal ovarian tissue with ovarian follicles in it and testicular tissues with testicular tubules in it. So their karyotype is 46XX. There can be mosaicism within the Y chromosome, or also they can have a karyotype of 46XY. Here the ovaries and testes can be seen separately, or can be seen combined in ovotestis. So this is one of the case which we operated, and on laparoscopic evaluation you can appreciate that there is this Mullerian structure, fallopian tube, which is going along. There is this ovary, and then there was another swelling in it, which was attached to this vas difference. So here this patient had separate ovaries and testes. In another case, there was a gonad where the ovarian tissue and the testicular tissue were separately seen. When the biopsies were sent for these patients, it turned out to be ovotestis for this patient and ovary and testis for this patient. And the most common combination is usually ovary on one side and ovotestis on other side. Other type of DSD is where there is pure gonadal dysgenesis. As the basic phenotype is that of the female, so either it's a testicular dysgenesis or ovarian dysgenesis, phenotypically they'll turn out to be female. They will have a bilateral streak gonads, and they are usually presented to OPD or to the clinics where they have a complaint of primary amenorrhea. Now, DSD can also be classified based upon the gonadal histology, where there are ovarian disorder of sexual differentiation, or it could be testicular DSDs, then there could be ovotesticular DSD, and then there could be dysgenetic DSDs. Gender assessment is a very important task, or is a very important legal complicated issue for cases of DSD, which is usually based upon the age of presentation, how the child is being raised, whether the child is being raised as a girl or a boy, what is the phallic structure look like, what does family wants. So this for as far as the surgeons are concerned, we do look at the external genitalia, what kind of reconstructive tissues are there, what kind of reconstruction we can offer to the child, and especially what kind of hormonal profile that child maintains, and how is he responding to various supplements being given. If we are converting a child into a boy, or we are doing reconstruction which is more towards a male gender, then we want that child should have adequate erectile tissue which will help him to have a phallic growth, and at a later date the child can also have erection and a normal sexual function in the later life. However, if we are going for a female genitoplasty, then we would definitely want to look if there is a good Mullerian structures, or as in case of CH they have normal Mullerian tissues. So likewise we do decide for the approach we can offer to the parents. So for gender assessment, it should be a well discussed, informed decision in consultation with the family, with the child, pediatrician, psychologist, endocrinologist, and the surgical team. There are various differential diagnoses, so one should be aware about them before labeling a child as a case of DSD, as DSD in itself is a big social taboo. So few things one should keep into mind, especially in the females: label adhesions, female epispadias, and imperforate hymen. While for the male, it could be a normal case of hypospadias with undescended testes, microphallus, or in case of isolated urogenital sinus. As I've already discussed, it is a multidisciplinary team approach. Managing a case of DSD is not easy, especially with its associated social taboos or social concerns. So we also need to have the backup support from the social workers, various support groups, and other teams. For deciding the treatment, it depends upon the condition that we are dealing with. Antenatally, CH is the only thing that we need to keep in account, and where the steroid support for female fetus will be needed, as we have already discussed. And if a newborn is born presenting in the shock with electrolyte imbalance, then we need to resuscitate the child and then do the proper management with the glucocorticoid or the flucod support for the patient with the salt wasting CH variant. Then these children needs counseling, various psychosocial supports, medical management, surgical management, and long-term follow-up. As far as the surgical options are concerned, it is said that the discordant gonadal tissue should be removed and should be sent for biopsy. While there is a controversy for markedly virilized patients, it is whether a male gender should be assigned to them or not. So at times this is being debated upon. While to assign a child as male, one functional testis and a reasonable penile tissue is must. While for severely undervirilized XY patient, it is better to offer them a feminizing genitoplasty, wherein gonadectomy, the male gonads could be removed and the estrogen support could be given so that they develop the female secondary sexual characters and can be recognized or define themselves as female in future. Cases of 5-alpha reductase deficiencies, their surgery should be delayed till puberty, and the exact time of surgery for cases of DSD is still controversial. It is the situation in the society. It again becomes very difficult for the patient, for the child to have a controversial gender assigned, or the to be in a situation where they don't know exactly what they are or how do parents introduce their kid to the society. So this remains a big concern and the question amongst all. Now the various male genitoplasty option could be a single stage or a stage repair, wherein initial correction can be done, a flap could be placed, flap or graft as needed, and then later on the urethroplasty could be done. Transposition correction can be done to make it cosmetically acceptable genitalia. In cases orchiopexy, gonadectomy are needed, and if it's males, especially in cases of ovotesticular DSDs, then the biopsy should be sent, and at times the gonadal prosthesis may be needed for these patients, especially if we are converting a child into a male patient and gonadectomy has been done for them. And excision of Mullerian structure is must if we are assigning a male phenotype to a child. Then various options are there for female genitoplasty, which could be as clitoroplasty, wherein approach of clitoral reduction, recession or resection could be done. Labioplasty, then vaginoplasty can be given, and the child may sequentially require vaginal dilatation in the initial period. If there is urogenital sinus, then we need to correct the urogenital sinus. At times they do require urogenital mobilization. In cases of CAH, early clitoroplasty is usually proposed after the control of their 17-OHP level on the glucocorticoid or the fludrocorticoid supplementation. In pure gonadal dysgenesis, female gender is assigned preferentially as they are phenotypically female, and not much reconstruction is needed to them. However, they are being counseled that there is gonadal dysgenesis in them and they will require lifelong estrogen supplementation. Now, gonadectomy is usually suggested in controversial or controversial gonads because there is associated risk of malignancies. Dysgenetic gonads are at the risk of gonadoblastoma. So CH usually they don't have any risk of cancer. However, partial androgen insensitivity and complete androgen insensitivity have been noted to have cancer risk in them. Now, vaginal pouch is seen in around 20 to 40% cases of severe hypospadias, not just DSDs, but in cases of severe hypospadias. It is usually difficult to calibrate such patients, so where then we can utilize double catheter method, or we can go for cystoscopy, cystoscopy guided catheterization, or we can at times we may need to drain the bladder suprapubically. It is advisable to remove the vaginal pouch whenever it's there, because otherwise they will have recurrent UTI or stone formation, and at times they have a dribbling post void. So vaginal pouch we have already seen in the previous slide. It could be appreciated upon the genitograms or cystourethograms. There are challenges in the post-operative care as they need a wound, they need proper wound care, and at times we need to counsel them for the subsequent procedures that need to be done on them. They need a proper psychosocial support, and thus social workers should be assigned to such families simultaneously. For hormonal support, they need to be in touch, or they should be in a regular consultation with endocrinology team. And it's better that the support group should be encouraged for these patients and their families. Lifelong support of hormones is usually needed in most of the cases. It is better for the better development of secondary sexual characters and also to support the assigned sex to these patients. So, to manage a case of DSD, it's a well organized, well trained, and institutionally supported multidisciplinary healthcare team support. So, managing a case of DSD is equally difficult as the diagnosis of DSD. One should be sympathetic to the family while discussing about the various options and the possibilities in cases of DSD. So it should be a patient-centered approach with proper social awareness, and with this lecture we intend to stimulate you that such situation is there and such congenital anomalies are there which can be treated and can be managed with various medical and surgical approaches. With the in the recent times there are various legal guidelines are being asked for in for the management of cases of DSD, and we hope that in future these children get a better treatment and the society is well aware and acceptable to cases of DSD. Thank you.